Hey you guys, welcome back for another week of topics and tips. So, all month long we are doing a study with me series from my review book. For NP week, happy nurse practitioner week, you guys. I hope y'all are getting all the appreciation and praises for all that you do. And those of you who are preparing and soon to be NPs, happy MP week to you guys too. I'm already praying for your success. So I'm already saying happy MP week because it's coming, you guys. But as I promised to you guys, the stuff that y'all requested that I go over, I wanted to do in honor of MP week. I do have some fun things for us as far as giveaways and things of that nature. Weber and Rhine is one of the things that was requested that I will go over today. And then we'll go from there the rest of the week. So we had Weber and Rhine, the asthma and COPD stuff, and antibiotics. So I do have some Weber and Rhine videos, y'all. And if you've seen any of my stuff before, I always say I don't know if it's I say Rhine, but I don't know if it's Rinne. People say it differently. So if I say Rhine, that's what I'm talking about. Sorry. But I have some other videos that I will add the links to as well. But let's just do it from the review book and study along so that y'all can hopefully this will just help you grasp the content better and aid in your studying, okay? But as always, before I get into anything, I always like to do my disclaimer and my welcome. So for those of you who are familiar with me, hey y'all, and for those of you who are new here, welcome, welcome, welcome. I'm Dr. Brittany Weinstock. I am a family nurse practitioner, and I'm the founder and CEO of the Nursing Studio. I design these videos, resources, and tools to help nurses and nurse practitioners to be successful on exams, boards, as well as in practice. I like to give the disclaimer because we know that there's no absolutes in medicines, right? So we treat and take care of patients on a patient by patient basis, but I like to provide you the guidelines and things so that you're able to gauge and quickly assess and do the things to be successful on your boards as well as in practice. But you also know that the boards, they're slower to catch up with the guidelines that we currently practice due to taking time to reinvent more testing exams, correct? So I like to provide you with the guidelines that are currently being tested on. And then if I'm talking about the things that we are covering in practice, I will let you know. But now that I've given you that big spiel, let's get into our studying, okay? All right. So one second. So I can turn to Weber and Rhine in my review book so we can study along. Because again, with my review book, I really put things kind of short and sweet to kind of just give you the nitty gritty. It's not going to be all your detailed stuff. I do that in my courses more, but it's not like the detail like you're starting from a book that you received in school. I just like to hit those common areas and oh, my picture didn't pull up. But sorry, I just realized that my picture didn't convert over. Anyway, so in this book, I just like to give it to you from the short and sweet so that you can kind of look at it, review it, read it. Then, like I said, we work through if there's medications, we have the medicines. Then there's the three different level interactive sections. So it's asking you about the condition, about the diagnosis and diagnostic exams, evaluation, and treatment. Because remember, I always tell you guys to study in the fashion of assessment, diagnosis, evaluation, and treatment, because that's how they test and that's how we practice, right? And that's about how we document our SOAP notes in a similar fashion. So just start to prepare your mind to think and function from that perspective. And then I also have the practice questions in the back of the book that we will get to on the topic that I'm covering. So Weber and Rhine, these are hearing loss exams that we do with a tuning fork, right? And these are conducted to assess for the sensory neural loss or conductive hearing loss, right? So typically in those scenarios, a patient has presented, they're complaining of some type of hearing loss, deficit, or abnormality or change. So you're trying to see, engage what is the problem, what is the cause, so we can determine how to move forward and treat, right? So, um, Again, sectioning it off versus conductive versus sensory neural hearing loss. I like to kind of give that foundational knowledge first, because if you can understand one versus the other, then when we break down the actual test of Weber and Rhine, then we can go a little bit more detailed as to what means what and be able to determine things, right? So with conductive hearing loss, basically something is blocking the sound conduction, the conduction of sound that is coming through to the ear, right? For those sound waves, right? So something is blocking that actual conduction of sound, like cerumen, or something is in the ear. You know, you hear of kids putting little objects, pebbles, toys, something in their ear. That actual thing, or the ear wax, the cerumen, something is blocking the normal conduction of those sound waves. So that's where they'll have those hearing loss. So you think of that because it is a conductive hearing loss, right? And the Rinne exam is one that strictly looks at that, and we'll talk about it. Now, sensory neural hearing loss is basically what it says. It's something else on the neurologic side or sensory deficit side that is causing the hearing loss. Things like presbycusis, right? So deficits from age-related issues, things of that nature, are your sensory neural. And so we look at our Weber to give us a clarification of whether we are looking at a sensory neural issue or a conductive hearing loss issue, and then we kind of use that Ren exam as a secondary exam, right? And looking at the book, I also throw in, because I like y'all to know that this testing is testing that acoustic cranial nerve, which is cranial nerve 8. And sometimes I just throw in little tidbits like that in the review book, because I like to give you key things that you may need to quickly think of and identify when you are preparing for boards as well as practice, right? All right, so let's get into the Weber exam and then the Rhine, understanding what those truly are. Because now that you know conductive hearing loss versus sensory neural, now we need to know, how do we determine those, right? So with the Weber exam, you have your tuning fork, you strike your tuning fork, and you want to place it in the center of the patient's forehead. So I always say, um, to think of it like the emoji, like the shrugging shoulder emoji, because to me it looks like a W to me, right? Like you're shrugging your shoulders like a W shape, because the two hands are going up like, and so I say the middle point of the W for Weber. This is just that Britney's Brilliance weird stuff that I think of to retain stuff. But during that center point of the W is where you're going to place that tuning fork, right? And then you're shrugging your shoulders and you're asking that patient, which ear do you hear the sound best? Now, they should tell you that they hear the sound equally in both ears. That's a normal finding, right? But if the sound lateralizes to either ear, we know there's some type of hearing loss, and that's abnormal, right? Now, if the sound lateralizes to the affected ear, that is conductive hearing loss, right? And why? What did I tell you guys? Conductive hearing loss is when there is something in the ear that is actually blocking the conduction of that sound wave, right? That so say it is cerumen in the ear, or a little kid did put a pebble in the right ear. So if you have conductive hearing loss, when you do the tuning fork, that sound is going to lateralize to the ear that has an issue. Okay? So wherever the pebble is, where this rumen is. If it lateralizes to the unaffected ear, that's considered sensory neural. Okay? Make sense? And I always like to tell the little tidbit, like Barkley gave this example years ago. I've done all the exams, all the review courses, y'all. And years ago when I did Barkley, I remember him talking about this, and it always sticks with me, and I always tell everybody about this. But if you stick your finger in your right ear. Yep, just do it. Stick your finger in the right ear, and if you just say, "I'm passing boards," uh, you will hear the sound lateralize to the ear that you have your finger in. But that's just an example when we talk about conductive hearing loss. Now, next, the Rhine exam. Now with the rind, you're striking that tuning fork and you're going to place it on the mastoid bone first. So the mastoid bone is that bone behind your ear, right? So place it on the mastoid bone and then you tell the patient to let you know when they no longer hear a sound. Once they can no longer hear that sound, then you're going to place the tuning fork right in front of that ear, right? And then you ask them to tell you when they no longer can hear a sound. So think about what we're testing. So when it's on the mastoid bone, that is testing bone conduction. When you place the tuning fork in front of their ear, you are assessing air conduction. You know that's it's in the air, the airwaves, and we're on the bone is bone conduction, right? Now, a normal finding is air conduction should be greater than bone conduction. Hence the reason why we place the tuning fork in front of the ear after we place the tuning fork on that mastoid bone, because we are looking for you to be able to still hear a sound when you're assessing that air conduction in front of the ear after you can no longer hear the sound when you had the tuning fork on the mastoid bone, right? So air conduction should be greater than bone conduction. It's said that it should be greater by a 2-to-1 ratio, but you only got to get that deep. I just tell knowledge when I think of knowledge. But if bone conduction is greater than air conduction, that's abnormal and indicative of a conductive hearing loss, okay? So does that make sense? Does that make sense? So we know conductive hearing loss is letting us know that something is blocking that conduction of sound, right? And then with sensory neural, we know it's some type of sensory or neurologic deficit or abnormality that is causing the hearing loss, things like presbycusis, right? We know we are assessing that acoustic cranial nerve, which is cranial nerve 8. And then we complete and use the Weber and Rinne test with our tuning fork to determine sensory neural versus conductive hearing loss, and to see, engage what ear we're having an issue with so that we can move forward and see how we need to manage and treat, right? So the Weber exam, we typically like to utilize that first. We're striking that tuning fork, placing it on the center of the forehead, thinking of that middle point of the W. We ask them which ear they hear the sound in best. They should tell you they hear it equally in both. But if it lateralizes to either ear, you need to know. So the patient presented with the issue with their right ear. If the sound lateralizes to the right ear, what type of hearing loss do we have? If the right ear is the affected ear and the sound lateralizes to that affected ear, is it conductive hearing loss or sensory neural hearing loss? Tell me in the comments. You should say conductive, right? If it lateralizes to the affected ear, that's conductive hearing loss. If it lateralizes to the unaffected ear, that's sensory neural. Now with with the Ron exam, we use that as like a secondary source, placing that tuning fork on the mastoid bone. So we strike it, place it on the mastoid bone first, ask them to let you know when they no longer can hear the sound. Then you want to place that tuning fork in front of the ear and then let them to tell you when the sound stops there for them. Air conduction should be greater than bone conduction. So if you strike that tuning fork and place it on that mastoid bone and tell them to let you know when they no longer hear sound, and they do, and then you put the tuning fork in front of that that same ear and tell them the same thing. They say, "I don't hear anything." That lets you know that the bone conduction is greater than the air conduction, and that is abnormal. That's indicative of conductive hearing loss as well. Okay, so you got it. So let me flip to our interactive section of the book. And let's see what I could ask you from this section. I really just asked you everything because this is not a assessment, diagnosis, or treatment issue. So tell me in the comments, if I strike the tuning fork and place it on the mastoid bone, and then I place it in front of the ear, is that the Weber exam or the Rinne? Tell me in the comments. You should say Rinne. Which cranial nerve are we assessing when we're assessing for the hearing loss? Say cranial nerve 8, and that's acoustic, right? With Rhine, what is a normal finding? Should air conduction be greater than bone conduction, or should bone conduction be greater than air conduction for your Rhine, your Rinne test? Air conduction should be greater than bone conduction, right? AC should be greater than BC. And then with the Weber, it should be heard equally, right? But if it lateralizes to the affected ear, we said that is conductive hearing loss. And if it lateralizes to the unaffected ear, that should be sensory neural, right? Let me see if I can find us a practice question to test your knowledge on that. Hold on. Flip into the back of the book. And this book can be found on Amazon, but this week I will be pulling names for people to get this book for 50% off. Uh, Hold on, y'all. I have some more things that I'll be doing too this week, so just hang with me. Make sure you're subscribed and make sure you're not missing out. So I will be doing some giveaways as well. What am I alone? Oh, okay. I think I see one. Okay, so a patient presents with complaints of hearing loss to the right ear. He states that he recently recovered from otitis media, but now he is having difficulty hearing. He describes the sound from his right ear seeming muffled. As the nurse practitioner assesses the ear with an ophthalmoscope, sorry, flip my thing. Sorry, I flipped the thing. All right. As the nurse practitioner assesses the ear with an otoscope, she notes that the tympanic membrane is not visible, and the CT scan shows that there is a cauliflower-like growth. Based on these findings, what is the best diagnosis? That's not a hearing loss question. Sorry. But what you got on that? Let's just test your knowledge. Is it A, otitis media, B, otitis externa, C, cholestoma, or D, sensory neural hearing loss? You should say C, cholestoma, right? That cauliflower like growth and appearance. It also usually has like a nasty odor, but that is classic and a key identifier. I saw hearing loss in one of those answer choices and thought that was one, but this is definitely one. A patient presents to the office today with complaints of hearing loss to the left ear. The nurse practitioner completes a Rhine and Weber exam. Rhine results show bone conduction was greater than air conduction, and the Weber is the patient states that the sound lateralized to the left ear. Based on these findings, how should the nurse practitioner diagnose? Is it A, sensory neural hearing loss, B, presbycusis, C, cholestoma, or D, conductive hearing loss? Tell me what you think in the comments. Matter of fact, based off the people who are getting these answers correct for today in the comments, uh, that's who will be able to get the book 50% off. Just make it easier. All right, so you guys, when I tell y'all, when we're doing practice questions, when you're doing questions on boards, your exams, read the stem of the question first so you can slow it down and actually answer what they're asking you, right? So the question stem states, based on those findings, how should the nurse practitioner diagnose? So we have a patient that's coming in with hearing loss, complaining of hearing loss to the left ear. The Rhine results are that the bone conduction was greater than the air conduction, and then Weber shows that they lateralized to the left ear. So remembering this, bone conduction is greater than air conduction. That means that's an abnormal finding, right? And you should think what? And then Weber, the sound lateralized to the left ear. Well, the left ear is the ear the patient is complaining of, right? So with that left ear, that is the affected ear. So therefore, your best answer choice would be D, conductive hearing loss. Because remembering that when you have conductive hearing loss, the sound will lateralize to the affected ear, and then that bone conduction being greater than air conduction on the Rhine um, test is indicative of conductive hearing loss as well. All right, you guys. I hope you found this helpful. Tomorrow we'll be talking about asthma and COPD. So make sure you meet me back here. Um, but as always, thank you guys for watching. Be sure to like, comment, subscribe, and share with whomever you may think may find this beneficial as well. Make sure that you are definitely following along. We will be doing some fun stuff for MP Week. Hopefully you're getting the answers right so you can get a chance to get this at a discounted rate. Again, I will be doing some giveaways this week, so stay along for the journey, you guys. You'll see here I have my contact number for the nursing studio on here, 803-400-6864. If you need me, if you need some one-on-one sessions, review sources, and things of that nature, feel free to reach out to me. Or you can just shoot me a nice email at the nursingstudio1@gmail.com. And I am happy to speak with you guys. I look forward to hearing from you. But be sure to meet me back here tomorrow. Bye, y'all.